Okay, Assalamualaikum and very good morning to Dr. Fairuz and our all my colleagues. Okay, today I will be presented about ophthalmology emergency, supervised by Dr. Fairuz lah. Okay, for the brief introduction, for the eye, we have for the anatomy of the eye, we have this is the eye anatomy. Eye is divided into 3 layers lah. So we have the most outer one is the cornea, the middle one is the choroid, and the most inner one is the retina lah. So for the posterior part, we have the in between here we have vitreous body, and anterior here we have the aqueous body lah, which is produced by the ciliary body. So there are 2 compartments here. Anterior compartment is between the cornea and the iris lah, and between the ligament there and the iris is the posterior chamber. So for the eye, it's supplied by optic nerve, and for the blood vessel, it's supplied by ophthalmic artery lah. So there are 6 extra ocular muscle of the eye. So we can divide it into medial rectus, inferior rectus, lateral rectus, superior oblique, and inferior oblique lah. So each of the muscle have its own function. So for the eye examination, usually we can do for slit lamp, visual acuity, pupillary reaction, tonometry, and fundoscopy. So this is the types of the eye examination lah. So the first one here is ophthalmoscopy, also we call fundoscope lah. So this is the test to see what is inside back of the eye. So next one is pupillary reaction. This is the usual one lah that we practice in ED to see the size of the pupil. So another one is the slit lamp lah. It is a type of microscope which is bring bright light used during eye exam. It can give a closer look to at the different structure at the front of the eye and inside the eye. For next, another type is tonometry. Tonometry we use to measure the intraocular pressure of the eye. It has few types lah, indirect. So I will not go further. So for the first emergency in ophthalmology is first acute red eye lah. It is the key worrisome clinical findings in need ophthalmology referral. So the patient will come with pain. Usually it indicate more serious lah pathology. For example, rhinitis, glaucoma. So it can be differentiate factor between emergent and non-emergent. So next one, patient will come also with discharge, either purulent or just normal discharge, and also the visual acuity. Pupils, if the pupil sluggish, we worried about glaucoma. The next one, patient also have ciliary flush lah. The redness is worse near the cornea. Usually it is serious intraocular causes lah, such as rhinitis and glaucoma. So for the red eye, we can there are a lot of differential diagnoses of the red eye. For example, conjunctiva, subconjunctival hemorrhage, conjunctivitis, rhinitis, and acute glaucoma. As you can see, the differences between these types of eye disease. For the subconjunctival hemorrhage, the conjunctiva will be very bright red lah, but other will be normal. The pupil will be normal, cornea normal, anterior chamber normal, and IOP normal. For conjunctivitis, there is discharge, eye is red, conjunctiva is red, and there is also associated with discharge, other is normal. For the rhinitis, the conjunctiva is injected. There are pupil is either small or irregular pupils. Cornea is normal, the anterior chamber is deep, and IOP normal lah. So the next is glaucoma. The entire eye is red. The pupil will be fixed dilated, and the cornea will be hazy lah. And IOP will be very high. So for the treatment in ED for conjunctivitis, we usually treat the disease with antibiotics lah. If patient is stable, no need for urgent referral. So another types such as corneal ulceritis or acute glaucoma need urgent referral to the ophthalmologist lah. So the next one is for the acute vision loss. The acute vision loss we can differentiate into painful and painless lah. So it can be either unilateral or bilateral vision loss. So for the painful unilateral vision loss, such as corneal abrasion, acute close angle glaucoma, inflammation such as iritis, uveitis, optic neuritis, endophthalmitis, retroorbital hematoma or any infection. So for the bilateral vision loss, it can be trauma, keratitis, epitoxic causes or trauma causes lah. So for the painless vision loss, it can be, if unilateral, it can be retina detachment, which is very serious, vitreous hemorrhage, retinal artery or vein occlusion, lens dislocation or ischemic optic neuropathy. For bilateral, it can, if bilateral vision loss, if painless, it can be stroke, side of medication, or psychogenic effect lah. So the next one, is glaucoma. So the glaucoma we can divide it into two lah. We have acute open angle glaucoma and closed angle glaucoma. So the most common in Asian people is closed angle glaucoma lah. It is pathophysiologinya, we have ciliary body which normally produce aqueous humor which travel around iris to be drained by canal of Schlemm. So when the iris is blocked, the canal of Schlemm, so there will be acute increase in eye pressure, leading to the rapid damage to the optic nerve and irreversible vision loss. So the symptom of acute glaucoma, patient will be presented with high intraocular pressure, there is headache, blurry vision, there is maybe corneal edema, redness of the eye, and pain in the eye and the eyebrow. Patient also will be presented with nausea and vomiting lah. So for the treatment of the close angle glaucoma, we can lower the IOP, such as we can give acetazolamide or timolol lah. Then we have to immediate referral to ophthalmologist. So the next emergency is retina detachment. It is the separation of neurosensory layer of the retina from the underlying choroid and retina pigment epithelium. So patient with retina detachment will complain about flashes of light, sudden appearance of many black spots, known as plotter. So patient will have gradual reduction of the eye vision, persistent painless blurred vision, or maybe patient will have like curtain-like shadow over either side of the eye lah. Also retina detachment also will, if there's long standing, there's no no symptom. Some long-standing slow retina detachment have no symptom until very late manifestation. So the few risk factors for the retina detachment, such as old age, ada history of the posterior vitreous detachment, myopia or trauma lah, and diabetic retinopathy. So the main treatment here is the surgical treatment. So we need to refer for ophthalm. The next one is foreign body. Foreign body, patient will complain symptoms of foreign body sensation. Sorry, suara tak ada. Tearing, red or painful eye lah. With stain, if we stain with fluorescent stain, eliminate under the blue fluorescent light. It is effective to see corneal epithelial defect. So in ED, the key management here, we have to irrigate with normal saline to flush out the foreign body lah. If unable to flush out by irrigation, the foreign body may be embedded in the cornea. So we have to refer to ophthalmology. So the next one is orbital blow fracture. This is trauma patient will be presented with pre-orbital chymosis, edema and emphysema lah. So patient also presented with ophthalmoplegia, which typically up and down gaze lah, which is double diplopia. If in severe condition, patient will have an ophthalmos. So in ED, we have to give ice pack to reduce the swelling, elevate the head of the bed to decrease the swelling. So if sinus have been injured, we have to give a prophylactic antibiotic and instruct the patient not to increase the IOP. So patient also we presented with nausea or vomiting, then we can give antiemetic lah. So we need to refer opthal for the assessment if it may be need for urgent treatment, such as patient presented with an ophthalmos and visual loss. So for the next one is Rupture Group. This is in a penetration trauma case that will lead to corneal or scleral disruption and extravasation of intraocular content. In this case, patient is presented with pain, decreased vision, hyphema, loss of anterior chamber depth or teardrops pupilla, and severe conjunctival hemorrhage. It can be diagnostic by Seidel test. So in ED, if rupture group is suspected, we have to immediately refer opthal. And we have to place eye shield to protect the eye from further manipulation. If can, we have to do CT head and orbit to evaluate the concomitant facial atau orbital injury lah. We also can start antibiotic within 6 hours of injury, such as ceftriaxone or ciprofloxacin. We have to give also tetanus prophylaxis, antiemetic analgesic lah. So the next one is retrobulbar hematoma. This is also in trauma patient. Patient will presented with presented with proptosis, ophthalmoplegia, increased IOP, pre-orbital chymosis, and subconjunctival hemorrhage. In this case, also we have to refer opthal in case it can lead to compartment syndrome of the orbit lah. So the next one is corneal injury. It can be divided either abrasion or laceration lah. The symptoms of the injury usually extreme eye pain, decreased visual acuity. So this is the type of the corneal disease that we can found in ED. First one is corneal abrasion. Next is corneal ulcer. Patient also can come with herpes keratoconjunctivitis or corneal laceration. So for the treatment of corneal abrasion, we can give analgesic je lah. Topical antibiotic if contact lens, such as ciprofloxacin or fluoxetine dengan tobramycin. So for the corneal ulcer, we can give antibiotics such as ciprofloxacin or fluoxetine juga. For the herpes keratoconjunctivitis, we can give oral cyclopia lah. For the laceration, if the small, we can give topical anesthesia or antibiotic. If large, we have to refer ophthalmology. So in ED, for abrasion, if topical antibiotic and follow up with ophthalmologist lah kalau small. If laceration more than 1 cm, we have to refer ophthalmologist to rule out group rupture and for possible suture placement. So the next one is chemical burn. This is the true ocular emergency lah. Patient either sustain acid or alkali burn. So if patient came to ED, we have to irrigate the patient lah. If possible, irrigate for 30 minutes using IV bag with normal saline connected to irrigating lens placed on the eye lah. Then close the eye and after few minutes, check the pH with litmus paper. We have to maintain a neutral pH of the eye lah, which is 7 for 30 minutes. So before irrigations, as the eye is very painful, we have to give the patient anesthetic drop lah to improve the efficacy of the irrigation. And sweep any furnaces to remove remaining chemical debris. So after irrigation, we can give the patient broad spectrum antibiotic such as tobramycin or ciprofloxacin. So, if conjunctiva and if we see conjunctiva and cornea appear white, it is a sign of severe burn. So this is the Roper Hall classification for chemical burn in ophthalmology. We have 4 grades. Grade 1 is just epithelial damage. Grade 2 is hazy. Cornea is hazy, but iris detail is still visible lah. Grade 3, there are total epithelial loss with haze that obscure the iris detail. Grade 4, the cornea is totally white. So this is the type of chemical burn that can occur. We have alkali and acid lah. For the alkali, it can cause coagulation necrosis, will denature the collagen and destroy the vessel. It's the most common and the most worst than acid punya complication. So it require immediate ophthalmology consultation. So it can be found in household cleaner or fertilizer. So for the acid, it will also cause coagulation necrosis. It is most common found in automobile batteries. So for the next one is the central retinal artery occlusion. For the Phatophysiology, it is the emboli to the central retinal artery leads to the ocular stroke. So the patient will be presented with sudden, painless, complete loss of vision, and also we can spot the cherry spot on the fovea. For the management, in ED we have to have very high index of suspicion, especially in patient with appropriate risk factor, such as old age, patient with heart disease, obesity, patient that smoking. So we have to immediate refer to optal, as a retina can be irreversibly damaged lah if more than 60 minutes. So then we can give mannitol or azithromycin once to reduce the IOP, and we can massage the orbit with finger lah to help dislodge the clot from larger to smaller retinal artery branch, and it help minimize the area of visual loss.
Okay, CRAO, Central Retinal Artery Occlusion, despite the name, it's a sudden, painless, complete loss of vision. And it's very important to do fundoscopy. Sebab then baru boleh nampak retina tu pale ke tak pale, the cherry red spot dan sebagainya. Sebab kalau just sudden loss of vision kan, so because sudden loss of vision is something yang distressing or very noticeable to patient lah. So it's something that you need to address. So bila patient present dengan sudden, painless, complete loss of vision tu, your mind should already be thinking, is this central retinal artery occlusion or not? So any sudden loss of vision is an emergency. So dah kena ada very specific diagnosis lah with regards to ophthalmology kan. So fundoscopy tu kena buat lah. Bukan fundoscopy ni nak tengok papilodema sahaja. So fundoscopy, sudden loss of vision, painless ke, painful ke, any sudden loss of vision, you need to do fundoscopy. So nak refer tu pun, optal pun akan tanya kan. And of course lah kalau bila refer, korang cakap ada blood and thunder appearance, ada cherry red spot dekat fovea tu, lebih meyakinkan sikit lah. Okay, carry on.
Okay, for the last one is for the cellulitis lah. It is infection
involving. Yang CRVO ada cerita? Kotlah saya tertidur tadi.
Cerita? Cerita apa?
Pasal central CRVO.
Tak
ada. CRVO tu yang painful
betul.
So dia sama je, sudden loss of vision tapi dia painful. So it's another ophthalmology emergency. So dia macam terbalik. CRAO actually despite the artery tu become occluded, it's painless. Dia bukan ischemia macam kaki. Tapi CRVO dia sakit. Dia loss of vision juga. Cuma satu lagi bila bercakap pasal ni, CRAO ni one of the treatment is to get patient to breathe into paper bag. Ni yang korang selalu buat patient hyperventilate kan, put flu mask kosong kan. dalam konteks CRAO ni, what you do, you ask patient to breathe into the back so that you increase dia punya CO2, vessel akan vasodilate and dislodge the clot tu lah. It's one of the things yang memang ni ada evidence lah, yang ada recognized treatment untuk CRAO. Tapi apa-apa hal pun still nak kena suspect dululah. Kalau CRAO pun tak terfikir, tak adalah follow up punya tu dan sebagainya. Okay, carry on.
Okay, for the last one is orbital cellulitis. It is an infection involving the contents of the orbit lah. So for the cellulitis of the eye, we can divide it into two lah, preseptal or orbital cellulitis. For the preseptal, it is unlikely to have complication. It is outside of the eye, so due to external causes lah, it can caused by Staph aureus, Staph pneumococcus or other anaerobe organism. For the orbital cellulitis, it can progress to loss of vision or brain abscess. So it is much more important. So it is associated with the paranasal sinusitis lah. It can be infected same microorganism as preseptal cellulitis juga. So for the clinical features, patient with preseptal cellulitis, we presented with swelling of edema, with or eye pain or tender of the eye. But no other symptoms. But patient with orbital cellulitis, there's eyelid swelling, eye pain and tenderness. Patient also have pain with extraocular muscle. Patient can be presented also with proptosis, ophthalmoplegia or chemosis and leukocytosis. So for the etiology, it is more in children lah. More in children, most common is bacteria rhinosinusitis. So for the management in ED, for the preseptal cellulitis, if there is no sign of orbital involvement, for adult we can be discharged. If for child, we have to refer first lah to ophthalm. Either they want to admit or just discharge the patient and give TCA or patient. So for the orbital cellulitis, we need to refer lah as need to started on IV antibiotics, or if in severe case such as orbital abscess, may need for surgery. Okay, that's all from me. Thank you.
Okay, so this is something that you probably encounter dekat green zone. So as Farah mentioned, ED disposition tu kena, especially in children lah, periorbital cellulitis, orbital cellulitis, preseptal cellulitis, apa semua ni, you need to refer lah. And in order for your referral to be convincing, kena check lah all the things yang clinical features ni. Kena bila refer tu kena mention lah, ada proptosis ke tak, ada ophthalmoplegia ke tak, ada vision impairment dan sebagainya. Okay, so tadi ada juga slide yang pasal acid dengan alkali kan. So yang tu pun basically treatment dia sama je. It's just a lot of irrigation. Irrigate sampai optal datang tak apa. Because the aim is because primary insult dah ada. Your aim of irrigation ni is just to prevent further secondary insult lah, and to dilute the harmful agents lah. Okay, so the things that you need to moral of the story lah, kita kata bila bercakap pasal ophthalmology emergency ni, any acute visual loss is an emergency. Tak boleh nak bagi TCA, no. Acute visual loss is an emergency. You need to come up with certain diagnosis and certain things that you need to do lah, kan. Acute visual loss is an emergency. Okay, but there are things yang macam nampak dramatik dalam mata ni tapi sebenarnya konservatif. Contohnya subconjunctival hemorrhage. Patient will be very concerned lah, kan, subconjunctival hemorrhage, because it can happen spontaneously, it can happen after patient sneeze, and it looks very dramatic kan. Tiba-tiba mata tu jadi merah kan, mata putih jadi merah. So and this is the sort of patient that you'll see dekat green zone. And this is the sort of patient that you need to explain very carefully what is, apa subconjunctival hemorrhage, what is the prognosis, why kita tak ada specific treatment, how long patient should expect that thing be there. Baru patient tidak tulis dalam Facebook kata saya pergi jumpa doktor tunggu 4 jam tak buat apa-apa pun. Kan? So bila benda berkait dengan mata ni kadang-kadang people get a bit anxious lah. Okay? So any questions?
No, doktor.
Tak ada kan? Sebab saya pun ada tertidur-tidur juga tadi, sorry lah. So ngantuk lah. Dah tua ni, tak mampu lah.